I still don't. So thank you very much again. I'm going to talk about fatigue. Is a real difficult theme. We are all confronted at the consultation about problems about fatigue. So I'm not going to save the world today. I'm just going to give you a few tips and ideas we're going to discuss, but I don't have the solution for fatigue in inflammatory diseases, obviously. These are my disclosures. And I'd like to start by a little clinical scenario, and I'm sure you've been confronted to that before, otherwise you are liars. My dear madam, I have excellent news. You are absolutely fine. No, doctor, I am not fine. I have fatigue. And then we all know what happens. This is what I call a very bad start, because as a doctor, it's going to be really difficult to start again after you make a big mistake like that. So we're going to talk about fatigue, but actually, what is fatigue? I'm going to use 2 minutes of this talk to make you do a little exercise. I suppose you have a neighbor. You have 2 minutes to discuss with your neighbor and write down a definition for fatigue. Good luck. 2 minutes. Not a synonym, a written definition of fatigue. It is obviously not easy, otherwise. Okay, so I'm just showing you some synonyms. You can find all the synonyms I find in the dictionary, but we understand that this is a difficult concept, and this is what is very paradoxical with fatigue, is that everybody has an experience of fatigue. I have fatigue, you have fatigue, everybody has fatigue, but yet is really, really difficult to define. So my proposal would be like a reversible reduction in physical and mental capacities, but I understand this is not so perfect. What I would like to share with you is that there is a great interest about fatigue. You know that each time you use Google to make a search, the search is actually stored and we can access what people have been looking for. And during the last decade, the search for the word fatigue has been increasing by 100%. And I must say that the country in the world which is the #1 for the searches is actually France. But you know we are always on strike, so well. So you're going to tell me, yes, but this is fatigue, in Espanol es fatiga. So I have looked at fatiga, and you will be happy to know that Colombia is the country #14 for the searches for fatigue. #1 is Paraguay, Chile, Cuba, Panama, Nicaragua. So it's quite interesting to see where people are looking for these words on Google. We know it's multifactorial, so this is why it's difficult to diagnose and manage. It can be lifestyle factors, it can be stress, it can be medications, it can be overwork, or it can be a disease such as lupus, Sjogren, rheumatoid arthritis, can be very tricky. So I have a question for you. Who believes that fatigue is the #1 most common and most bothering manifestation reported by lupus patients? Before even joint pain, who believes fatigue is the #1 manifestation? Please raise your hand. Well, I'd say 50%, and you are correct. This is a study I've been privileged enough to coordinate with Lupus Europe. You see there are 4,000 lupus patients answering. They do report fatigue as the #1 most common and most bothering manifestations. And also, if you are using Twitter, I think many of you are, when you look at the tweets from lupus patients and you analyze them with automated tool, fatigue is one of the most common thing that comes back. So in my department in Strasbourg, we've been really interesting about that theme, because during the consultation, it's difficult to manage fatigue because I think we don't really have the time for that. In 15 minutes or 20-minute consultation, if we have to renew clinical examination, write the prescription and so on, it is difficult. So we surveyed a large sample of patients, and just to give you some numbers, 70% of lupus patients report significant fatigue using validated scales. And when you look at the characteristic of this fatigue, 40% of lupus patients have severe major fatigue, again, according to validated scales with thresholds. So this is a big, big burden for our patients, with, of course, as you know, a big impact on the quality of life. So really the question is, what can we do to help our patients go better? So with some of our residents, actually, we've been thinking a bit and writing this paper. I am going to show you quite a few QR codes. Get your telephone ready, because I'll show you some useful stuff you'll see in a minute. So the first point is that fatigue is a very personal experience. So we need to assess it in a calibrated manner using standardized tools. Otherwise, my fatigue is different from your fatigue. And if we want to help the patients, I think it's nice to collect the data. And I don't know if you know that, but EULAR has an online PRO library. All the PROs you want in any language, including Spanish, you can find them on this website. So you have function, pain, fatigue, depression, you have all the scales you dream of. And for fatigue, there are two scales that I think are really interesting. Is facet fatigue and is 5 FSS. And if you have your telephone and you screen these QR codes, you import in your telephone the scales in Espanol. So this is really useful for the consultation. They are difficult to find, so you got the link with this. It goes direct in your telephone. I can show you the slide later if you want. So I must say that in the end, you can also ask a patient on a 0 to 10 scale, how intense is the fatigue? It is well correlated with fully validated scales, but it is of course less precise, and it does not assess the different domains of fatigue. So we're going to review a potential strategy that you can use. I think the first step is to rule out common medical causes. So this is a question for you. Which common causes of fatigue, organic causes, real causes, do you have in mind? What do we need to rule out? Can you just raise your hand and shout a proposal? Sorry? Sleep troubles. Okay. So in my mind, it could be sleep apnea because of weight gain due to corticosteroids. Any other organic cause of fatigue? Very common in our diseases. Anemia, of course. It can be anemia, it can be calcium problems, organ failures, adrenal failure in patients who stop corticosteroids. In the next 6 months, you can have fatigue as the sole manifestation of a slow adrenal failure. Thyroid problems, diabetes, lymphoma. Obviously, before saying it is psychological, we'll have to rule out these manifestations with simple, not too expensive, little blood tests. And it can be done quite easily. TSH, calcium, is quite okay. It's not a $1,000 tests. Then I think it's important to check whether the autoimmune disease is active or not active. What the doctor actually meant in this example, I think, was that the lupus was not active, not that the patient was okay. It's not the same. And in our study, we found a significant, small but significant association between disease activity and fatigue. So I think it's really important when the disease is active to control its activity. And we understand why. We've had a question about fever, but it's the same with fatigue. An important element of the immunology of lupus is interferon alpha. And you know how you are when you have a flu, a viral infection, you have fatigue. So there is a biological reason for fatigue in systemic lupus when it's active. So when lupus is active, the step is to control disease activity using any treatment you want. Most of them, it's not proven, but some have good data to show they improve fatigue. Is the case with anifrolumab, is the case with belimumab. But my guess is that any treatment helping to control disease activity will help with fatigue. Then if you do not have disease activity being active, we have to search for confounding factors, and this is where psychological manifestations can go into. But one I would like to quote specifically is pain. In all studies we have in rheumatoid arthritis, in systemic lupus, pain is a major predictor of fatigue. So if a patient is reporting painful manifestations, we need to account and control pain. And for instance, it's typical with joint involvement. Of course, there will be a loss of function, but most of these patients will report sleep problems because of the pain, and with the sleep problems, significant fatigue. So we have to deal with this in our way. I would like to quote this study because I think it's really interesting. It's a Canadian study from Zahi Touma. What he did is that he followed fatigue in time and he followed disease activity. And what he shows is that it's slightly correlated, but fatigue is not fully explained by disease activity. Actually, what he found is that the trajectories with the highest levels of fatigue are the one correlated with fibromyalgia. You are not going to be surprised. So what can we do? Well, I'm going to show you in a minute. But we know that the prevalence of fibromyalgia is obviously very high in our disease. We can have lupus and fibromyalgia. This is quite common, and it may be difficult to distinguish. So I told you about the LEAF study, the online system that we have invented in a way. There are 1,250 patients that tried this tool, online tool. 60% had a positive screening for fibromyalgia. So it's not definitive diagnosis, but it's positive screening. So it's obviously a big problem. The second thing we have to discuss is psychological issues. When you ask a patient to report how well he feels, we are already convinced that depression, stress, anxiety are very well correlated with the perception of the patients of their own disease. A depressed patient will tell you that his lupus is worse than a non-depressed patient. This is fully studied in literature and intuitive. And indeed, in our study, we found a very strong association between anxiety and depression and fatigue. Having one of both multiplies by 5 the probability of fatigue. So we did something which I think is interesting. We took the patients and we put them in a cluster analysis. And I'm sure you are going to recognize some of your patients. We found 3 clusters of fatigue. The first cluster is a huge majority, 2/3 of patients. They have little disease activity and little fatigue. They are quite okay. On the other side of the spectrum, you see it's a minority, just 7% of the patients. But these patients, they have high disease activity and high fatigue. But in that case, we know what to do. We are going to treat active lupus. What is more difficult, I think, and what is a problem at the consultation, is the 25% that remains. These patients, they had no or very little disease activity, and they had very high fatigue score, very high depression score, very high anxiety score. And these are the patients which I believe are the most complicated to manage when they report fatigue in the consultation. It's up to 25%. So what we should do, or we can discuss, are targeted intervention, but we all know that there is not much that is proven to improve fatigue. There are a few studies with vitamin D. As rheumatologists, we already know that if we find a deficiency in vitamin D, we need to correct. I honestly don't believe it helps with fatigue, but anyway, it has to be corrected. So we can always say there is a bit of data showing that by correcting vitamin D, it may help improve your fatigue. What is your main tool against fatigue? I'm curious. What do you suggest to your patients? I agree. Exercise. There are randomized controlled trials proving that fatigue in lupus is improved by physical activity. These are small randomized controlled trials. The statistical power is not very high, but yet I think it's an important tool. And we are working on international recommendations for physical activity in systemic lupus, because there are a few things interesting: photoprotection, not jumping on inflamed zones. But I'm showing you a kind of summary. It can be helpful if you want. But I think we are always facing the same problems. The patients tell us, but doctor, I am too tired to do physical activity. And so I think the secret here is to start very slowly, to break the vicious circle, to say, well, you should start by 5 minutes. 5 minutes is okay. And the patient will tell you, yes, but I have a target. My target is 10,000 steps per day, and I cannot do it. I think it's nice to know this study by the Lancet in 2022, showing that this 10,000 step per day target is actually not validated fully in a great manner. You achieve health benefits as soon as you do more than 5,000 steps per day. So I think we should tell our patients, don't be bothered, don't target 10,000, this is way too much. If you do less, you already have significant benefits. I think it's great to tell the patients because most of them track their physical activity with the watch or the telephone. Just coming back to this tool I've shown you before, Leaf, because this is free, I don't have copyright on that. I think this will be a way to help our patients. So this is an automated system. Patients answer questionnaires, and we have been lucky enough with the help of several colleagues from Latin America to have 1,250 lupus patients testing the tool and providing feedback. So we are asking questions. For instance, they have the fatigue, they have the MFI, they answer questions about pain, sleep quality, depression, and so on. And what we have shown is that a huge majority of them have very significant fatigue, and that the prevalence of these different manifestations is very high. Stress is very high in our patients. Sleep problem is very, very high. So this has to be taken into account. And as I said before, what is interesting with this tool is that it provides automated feedback. It gives a personalized feedback to the patients. So I think it's very useful. So this is my last slide. I'm coming back to what I've shown you in my main talk before. Obviously, there are many things that are strictly medical that we need to do to target remission, control disease activity, use the treatments. But we should think that about 80% of a patient trajectory is actually not in the hands of the doctors. The patients have to take care of themselves with lifestyle management. And I think fatigue management is a very, very important step of that. And we need, as doctors, to advise them that basic tests should be done and that we should address these comorbidities, including psychological comorbidities when it's needed. Thank you very much.